Welcome to EmCyte's webinar series. Join us as we explore the latest clinical insights and the science behind precision biologics.
Welcome to tonight's session in the Regenerative Edge webinar series. This is our second webinar in the EmCyte, and we are pleased to have an excellent lineup of experts joining us. Our featured speakers tonight is Dr. Moises Erizari, a highly respected leader in sport medicine and regenerative medicine with practices in both Miami and Chicago. I'm right. Tonight, he will be sharing his clinical expertise on how and when he chooses between the PRP, the fat in general, microfat or nanofat, and a bone marrow concentrate in musculoskeletal care based on real-world decision making. We are also joined by Dr. Randy Miller, a great and renowned plastic surgeon in Miami, and Dr. Gayan Povendran, an experienced regenerative medicine physician and one of the key leaders in this field. So both of Dr. Povendran and Dr. Miller will serve as panelists for our Q&A question and answer session later this evening. To start us off, I'll spend about 10 to 15 minutes reviewing the core science behind of the three orthobiologic options, PRP, fat, and bone marrow. We'll look at their cellular component, growth factors profile, and key differences that influences their use in clinical setting. And as we go through the session, please feel free to submit your question in the chat. We can see that. And then at the end of the webinar session, we're going to discuss on that. We will address them during the panel discussion with Dr. Povendran, Dr. Miller, Dr. Erizari, and I. Finally, we always welcome your feedback and topic suggestion for future session. This series is designed to support your clinical decision and help you stay current in the field. With that, I'll begin with brief overview, and then we will hand over the presentation over to Dr. Erizari for his clinical insights. Okay, let me share my presentation. Okay, everybody can see that. That's great. So, the topic we choose for tonight's presentation, what, when, and where, choosing between the fat, PRP, and bone marrow, which is very critical because still there are lots of debate for which indication, which pathology we need to use, which one. So we are going to discuss on that tonight, and hopefully we could address lots of your questions. Okay, so okay. The regenerative medicine in orthopedics field often utilize orthobiologics, natural biologic substance derived from the patient as autologous biologics to promote tissue healing. Three commonly used orthobiologic treatments today in its society and market is the PRP, microfat in general, fat graft, microfat, or a nanofat, and also bone marrow biologics, could be bone marrow aspiration or bone marrow concentration. So regarding to the PRP, we have in general two choices: test tube PRP or a commercial kit, which provide us the clinical PRP. So about the test tube, we talked a lot, and which is not a PRP, because it gives you the best case scenario, just 2x concentration, but today there are lots of different commercial available kits in the market based on the different feature they could provide the PRP as a clinical PRP, which is very important, the dose and the platelet number and other components of the PRP, and we're going to talk about later more. So, we could prepare the PRP through the single spin if we want to use the kit, commercial kit, or double spin, and our choice is definitely double spin since it provides us a significantly higher platelet recovery and also gives us the flexibility to have different formulation. So we talk about the different formulation. We had this conversation in our previous the webinars regarding to something beyond of the platelet, which is other components in the blood and PRP. We need to consider them, and with the double spin and with the commercial available kits, specifically EmCyte kit, we have that opportunity to make different formulation for our practice. So we talk about the real PRP, real clinical PRP, and I just brought one example based on the new generation of the EmCyte kit, which is going to be available in market soon, probably in next week. When we talk about the real PRP, clinical PRP, we mean these types of kit and these types of PRP. If you look at the result and data, you could see for leukocyte poor PRP, we have over 90% recovery of the platelets, which gives us the clinical PRP with high amount of platelet recovery. Otherwise, if we have just 2x or 3x recovery, it won't be sufficient to get the best outcome we usually expect. So that's why from now and so on, when we talk about the PRP, we mean this types of PRP, not test tube and not anything else. So about the PRP, we talked a lot, and we know in the PRP, the superstar is the platelet. It's the brainless genius. So, and it provides us all of the beneficial and all of the favorable things based on the granulation after activation of the platelet, and it provides us the growth factors and all of the cytokines we need for regeneration, and also we need for immunomodulation for our practice. Based on the indication and pathology, we could decide what is our aim, and then we could probably change the formulation mostly toward that aim. But the superstar, the main player, is the platelet. And we talked about the platelet a lot, and you know better than me. In the literature, we talked a lot, and we know that the main action comes through growth factors and cytokines. So when we talk about the beyond the platelets, we know we have some other key components, like in general white blood cells, leukocytes, that can influence on the outcome of the PRP properties and also outcome of our practice. So mostly in the market now, in the society now, we know the leukocyte poor and leukocyte rich, which is not correct terminology, and we have been trying to correct that as leukocyte poor, which is the pure PRP with the minimized amount of all of the leukocyte. And then based on new innovation we introduced recently through the market, we could have monocyte rich. We have that flexibility to increase the monocyte number and recovery alongside with the platelet recovery as a new formulation. And also we could have neutrophil rich alongside with the monocyte and lymphocyte and platelet. Based on different indication, we could decide which one, and then we could get different properties and different outcome from them. And as you can see in the picture, we have usually leukocyte pore as golden PRP, which is famous in the society and market, and then a little pinkish. Now we use that for a monocyte rich and a little reddish for the neutrophil rich PRP. Beyond of the platelets and PRP, we have two other actually one other modalities as the autologous orthobiologic. As a general, it's going to be stem cell therapy. So when we talk about the stem cells, we mostly and we actually mean mesenchymal stem cells, or MSC in general, which were first identified in bone marrow in the 1960s and are known for their regenerative potential. And today, the two most common sources of autologous MSC are bone marrow and adipose tissue. We could extract the MSC from other tissues, but for orthobiologic, the main two sources is the bone marrow and adipose tissue. While they share many molecular and biological features, there are lots of debate still in the society which source is the better for which pathology, and we are going to talk about tonight. So clinical research shows that both type of the bone marrow mesenchymal stem cells and adipose-derived mesenchymal stem cells offer comparable regenerative and immunomodulatory benefit, but with some minor consideration, we could use them instead of each other for different pathology and indication, and we're going to talk about this. So in general, if you look at in this table compares the marker expression and marker profile for adipose tissue, adipose-derived stem cells, and bone marrow-derived stem cells. In general and commonly, we know the stem cells based on the couple of the highly expressed markers like CD73, CD90, and CD105 positive. And if we have CD45 minus, negative, and CD14 and CD34 negative, we consider that together as the stem cells. But about the CD34, there are some consideration because maybe it's misunderstanding at some point, because in bone marrow in general, we have CD34 positive cells, but they are not MSC. They are progenitor cells, but they are not MSC, and we can get the benefit from them. And also in the adipose tissue, also we have the CD34. If we talk about later, it's going to be other progenitor cells, but it's not specifically MSC, and just keep in your mind. And among all of the similarity we have for the MSC and cellular in the general, all cellular components for the adipose tissue and bone marrow, we have some differences, which is specifically here, if you look at the table, for adipose tissue, we have CD36 positive and CD106 negative. It's totally vice versa in the bone marrow. And these minor difference gives us a big difference in the outcome. And the properties of the MSC and in general stem cells in these two sources could be totally different. And we can consider one of them for one specific purpose, another one for another specific purpose. So if you look at this table, I explain very briefly and with detail. This contrast reflects the fundamental functional differences between bone marrow stem cells, mesenchymal stem cells, which are more adhesion and immune regulatory via CD106, while adipose tissue derived stem cells are more angiogenic and metabolically active via CD36. A systematic review also, when I checked, confirmed these differences and highlights the variability in CD34 and CD31 reporting across the adipose tissue derived stem cells study. So based on that, if we need more angiogenesis, maybe we could consider in general adipose tissue stem cells. But if we want have more immune regulatory, maybe we could better consider more bone marrow stem cells. But it's just general. There are lots of other consideration we need to consider them. Another thing regarding to the cellular component beyond of the mesenchymal stem cells, both sources provide us white blood cells, platelets, and red blood cells, but at different quantity. So if you look at the table for white blood cells, definitely we have more quantity in the bone marrow compared to the fat in general. We have bone marrow concentration and we have also bone marrow aspiration. I'm going to talk about the difference of them. And compared to SBF in a general or fat derived stem cells, you could see the difference, how big is the difference between them regarding to the white blood cells, red blood cells, and platelets. So as you can see in bone marrow concentrate, we have in all of these cellular components, we have the highest quantity compared to the bone marrow aspiration and compared to the fat. Regarding to the growth factors, there are lots of similarity, but based on recent study published in 2025 January, they already analyzed and measured 200 different cytokines between bone marrow in general and adipose tissue, and they found that in over 120 cases, cytokines on those 120 cases, they're gonna release and secreted more in bone marrow significantly compared to the adipose tissue. The only exception was the hepatocyte growth factor, which is already 10 times more. We have hepatocyte growth factor in the fat graft compared to the bone marrow. So, and which is one of the key players for angiogenesis. It's another reason we could consider fat in general, I mean adipose tissue, stem cells, adipose tissue graft for angiogenesis purposes rather than the bone marrow. There are some question and debate. Okay, in bone marrow we have hematopoietic stem cells, progenitor cells. They create the smooth muscle cells, endothelial cells. Why we consider the fat as the best source for angiogenesis? So one of the reasons is this, and some other consideration I'm going to talk about later. So about the bone marrow in specifically, bone marrow is obtained from the patient's bone marrow, typically aspirated from the iliac crest of the pelvis. Mostly the volume is going to be between 30 to 60 ml, and usually the small aliquots from the multiple site on the crest to maximize the cell yield. The most common and generally preferred site for bone marrow aspiration in adult is the posterior superior iliac spine, which is famous as PSIS, and Dr. Irizarry will give us more insight about that. But we can also get the bone marrow from other sites like femur, like humerus, but it's not very common. The best one and the common one is the aspiration from PSIS. So In bone marrow, we have different cellular organization, and it follows a depth-related gradient. The most closest one toward the bone layer is the quiescent hematopoietic stem cells, reside near the endosteal surface, closely associated with the osteoblast and bone lining cells. This region also contains osteoprogenitor mesenchymal stem cells, which contribute to bone remodeling. As hematopoietic stem cells activate, they migrate to the subendosteal prevascular niche, where they interact with the endothelial cells, precyte, prevascular mesenchymal stem cells, especially nestin positive and NG2 positive subtypes. Deeper into the central bone, we find committed progenitor and dense population of the leptin receptor positive mesenchymal stem cells, and also known as CAR cells, CAR cells, surrounding sinusoidal vessels. In the pre-sinusoidal zone, mature blood cells, adipocyte and immunomodulatory MSC help maintain the hematopoietic balance, and we could find these types of cells in the deeper side of the bone marrow. So, but one question usually we are facing with the society is choosing BMA or BMC, and there are lots of debate about that. What's the difference? The BMA is the bone marrow aspirate, but we don't do anything regarding to preparation after aspiration, like filtration and centrifugation. BMC is the term after aspiration, we need to filter, and also we need to centrifuge that to concentrate the components. So still, there is a debate. Sometimes some of our friends believes that we don't need to do further preparation, and in this way we can keep the bone marrow more natural and without any further manipulation, but which is not true in the human body. So definitely the cells are going to be ready for some manipulation, and specifically stem cells, they are very strong for some manipulation. They cannot be easily changed in their fate, specifically bone marrow stem cells. So if you look at some of the data comparing the BMA and BMC, you can see in all of the parameters, good parameters like the number of the CD34 positive, CFU, total nucleated cells, bone marrow concentrate, significantly better than the bone marrow aspirate. And regarding to the hematocrit, red blood cells, and also platelet number, again, for all of them, we have better numbers in favor of the bone marrow concentrate compared to the bone marrow aspirate. Because when you aspirate, for example, 30 ml or 60 ml and don't concentrate that, you need to use all of them. And sometimes we cannot use them. We need to minimize the volume and keep all of the key components as concentrated as possible. Regarding to the growth factors as well, you could see the PDGF, IGF, TGF beta, and VGF. In all of them, we have better outcome, better numbers for the concentrated one. That makes sense because in concentrated one, we have more platelets. So, and some of these growth factors can be secreted in parallel from the platelet as well. So all of the results, the literature shows better outcome for bone marrow concentrate compared to the bone marrow aspirate. Regarding to the fat, in human body, we primarily have three types of the adipose tissue: white, brown, and beige fat. So the white adipose tissue, especially and specifically, we can find them through the subcutaneous abdominal region, and are most commonly harvested and is our preferred source for regenerative purpose because it contains the highest concentration of the adipose-derived stem cells. In the beige, we have somehow the stem cells, but in the brown one, we barely could find the stem cells, and it's not favorable for regenerative medicine. So fat is typically collected using mini liposuction technique under the local anesthesia, using blunt cannula to gently harvest the subcutaneous fat while preserving the cellular viability. The aspirated fat is then filtered or washed to remove the impurities. To isolate the regenerative element, fat can be processed through the enzymatic digestion, which yields the better number of the cells, but in the regulatory aspect, we don't have that, I think, regulatory allowance to use the collagenase, and it also digests lots of the ECM proteins. So we can use the mechanical method to make it more fragmented while keeping the ECM protein and ECM feature and preserve that in a native extracellular matrix and are compliant with the minimal manipulation regulation. Fat graft contains adipose stem cells, precytes, endothelial cells, immune modulating cells, and other white blood cells like bone marrow, but in a less quantity. And also it has something between 300 to 500 times more mesenchymal stem cells per volume than bone marrow. But there is a consideration. When we use the mechanical preparation, we cannot release all of the cells. Still, lots of cells are embedded within the structure. If we want to have more cells, free cells, we could consider enzymatically digestion, which is not recommended. So fat grafts are used in the three main forms, usually macrofat for structural support, microfat for better integration, and nanofat, which is highly processed for regenerative signaling. And regarding to the fat, also we have the four major groups of multipotent cells within the fat tissue, like the bone marrow, which have different progenitor cells and different multipotent cells, not just MSC. In the fat also we have different ones. If you look at the green one, they are representative of subendothelial progenitor like precytes, and other related cells like subendothelial progenitor translational population. If you look at the blue category, we have the vascular wall residence endothelial progenitor cells. In the violet, we have vascular wall hematopoietic progenitor cells, and the black category, we have white fat progenitor cells. So some of the common markers used for distinguishing between the different population, but still some of them are not clearly discovered. So in my part, based on the different feature, molecular and phenotype of the molecular feature and phenotype of the different source of the stem cells, basically bone marrow and adipose tissue, if we want to consider the regenerative potential, we could say in bone marrow-derived stem cells, we have effective healing with bone marrow for bone and cartilage tissue. We have higher osteogenic potential due to development of the proximity to the bone and secrete the key differentiation factors for skeletal regeneration. In contrast, if we want to consider adipose-derived stem cells, they're going to be superior in angiogenesis and based on the basic science and molecular aspects, they're going to be more suitable for soft tissue and wound healing, highly effective in muscle and tendon repair, as well as the chronic wound. And also, their secretum is rich in the VEGF, HGF, and promoting blood vessel formation. And also for spine disc degeneration, although personally, I'm the fan of the bone marrow for that case, but some new result shows fat works comparable to the bone marrow and even better than bone marrow for discal regeneration. And regarding to the immunomodulation and anti-inflammatory effect, so both of them, bone marrow and adipose tissue, share the same properties, suppress the inflammation via macrophage M2 and Treg cells mechanism. And specifically for adipose-derived stem cells, it has a strong immunomodulatory activity in preclinical models in the literature, and also constitutive secretion of the interleukin-10, interleukin-1 receptor antagonist, which is famous as IRAP, PGE2, and TSG6, and effective in soft tissue inflammation, while bone marrow-derived stem cells, mesenchymal stem cells, which is mostly potent for immunomodulation for the joints and specifically for osteoarthritis and reduce more inflammatory genes in the osteoarthritis when we use the bone marrow specifically. So thank you so much for my part, and it took a little longer, sorry.
Excellent. So should I start now then?
Yes, please.
Good. I'll be mindful of everybody's time, so I'm going to just share my presentation here real quick. Let me share my...
I need to stop. Okay.
No problem. Yeah, I got it here, and let me see. Do you see it now? Oh, yeah. Screen and share. Let me know if you see my presentation. I'm going to... Okay, let me see. Present. Okay, do you see it now?
Yes.
Excellent. Let's start here real quick, and I'll just be mindful of everybody's time. So first of all, let's talk about what happens in practice with all these. I mean, it's good to know the theory. It's good to understand it. But more important than that, it's good to choose when to use it and what patient to use it so that you can achieve a good outcome. And therefore, so patients learn to believe more in this field that continues to grow. I mean, over time, we're constantly learning over time, all of us, and that way, it leads to improvement overall. So I'll give you some decision-making rules. None of these rules that I'm going to be presenting, it's something that you have to either know by heart or they're not carved in stone. I want you all to use this as guidelines, right? It's something that can help you make a decision. And if at some point you have a doubt with a decision in a patient you have, I mean, make sure to contact us and we'll try to help guide what you're doing, and we'll all learn in the process. Now, briefly, as we know, the main differences between the three that I'm going to be talking about: PRP, which is a blood draw for place and concentration; the adipose-derived stem cell obtained through harvesting; and the bone marrow through a bone marrow aspiration. Right? That's just briefly. Now, In the process of platelet-rich plasma, and there's 1,000 different preparations of platelet-rich plasma, which you all need to understand in order to be able to better treat a patient, right? It's not as simple as leukocyte-rich and leukocyte-poor. There's a lot of other components that if you understand them better, you can sometimes inject a patient with minimal discomfort and obtain the same or even better result. So it's a simple blood drawn centrifugation that will promote healing and will reduce inflammation. Now, what are the benefits of that? Sure, improve healing, improve recovery time, and studies have shown that there's strong evidence of the benefit of its use for tendinopathy. See, I put it there in blue so that if you're just passing this in 2 minutes that you have to review it, you can remember. Tendinopathies and mild osteoarthritis. Even in some cases of moderate osteoarthritis, you will see improvement, but for the cases of mild osteoarthritis, you will see great improvement. Another benefit is it's not costly to the patient, and this is just easy to obtain and easy to process in your office. What you have to keep in mind, as I mentioned before, there's many different preparations. There's companies that want to sell you just a yellow tube to prepare it in your office and will not give you the yield you have. And in the end, it will hurt your own reputation, right? Because patients are not getting better. Now, while it helps with discomfort and it helps with a lot of soft tissue, it does have limited regenerative potentials at the time of talking about cartilage or meniscus, for example. Now, if we compare that to the adipose-derived cells, right, which the mechanism, yes, it involves a lot of differentiation and paracrine effect of cells, but the advantages are not only a typical patient may have an abundant of adipose tissue, right? But also it's has strong anti-inflammatory effects. Now, one thing that I have noticed over the years is that, there's a reason why we're actually trying to break that fat a little bit. It's because that fat is thick and it won't go through a syringe easily. So even when you break it a little bit mechanically, that fat has still it produces a mass effect, meaning it's great for joints that are starting to collapse or are reducing space. I use the word collapse, right? Or even a tissue like a hip where you have to offer some distraction and strengthening up the muscle. It's good to also get it in there because it helps separate the tissue a little bit more than something that's a little more fluid. So that's something to always to keep in effect. I use it a lot in cases of people who have tendon tears with some retraction. Not only do you want to inject it in the tear, but remember that the tear is a space. I like to inject it in both sides of the tear so that its own mass effect can push and approximate the tendon tissue a little bit and therefore produces a better effect. Now, it has shown to have great outcomes in healing and pain reduction. And it can be used for mild to moderate osteoarthritis, even in some cases of severe osteoarthritis, but especially of the knee and hip. Now, it has multiple uses. One problem I see, or we have to keep in mind, one consideration with adipose-derived stem cells is that we're not all experts in liposuction like Dr. Randy Miller, right? We're not all plastic surgeons, but at least the good thing is we have to obtain just a little bit of fat if you're treating a simple joint. But what happens when a patient comes who is an elite athlete and barely has any fat, and they say, can you obtain it from here? Trying that could cause a cosmetic defect, so you have to be mindful of that, right? Fat is very forgiving if you take it from the love handles, but in other tissues, it might be a little problematic, and it's a long procedure that it can be time-consuming if you're not used to doing it. Now, you compare that to a bone marrow aspiration, which is minimally to moderately invasive. It has a lot of effectiveness for the regeneration of cartilage and bone tissue. So for cases of non-healing fractures, for example, is great. For cases of vascular necrosis of the bone on the hip, I have a lot of patients like that. But it doesn't have that mass effect as much as the adipose tissue has. It is quite safe. And the main concern is actually patients' fear that they think you're going to their spine, but in reality, you're going to a very, very safe area of the pelvis, not the hip. And, some patients after 2 or 3 weeks, they still have some pain on the extraction site. That feels like a bone bruise, right? It is skill dependent, but it can be easily learned. Another consideration you need to have is that as we age over time, yes, we accumulate more fat, but we actually have a lower mesenchymal stem cell yield from the bone marrow. Now, going to what we need to know and learn today. Number one, yes, these treatments are great, but we have to remember and be mindful that these treatments are not everything. They're not the God, right? They need to be accompanied by good patient compliance, physical therapy, and all other modalities that are important and can help bring us a better outcome with the patient, such as shockwave, etc. Right? It's also important to follow up the patient and give patient clear instructions, because I've noticed over the years that some of the patients that fail treatment are simply because they did not understand what was going on or what they needed to do and ended up damaging the work we were trying to do. And follow up. Always offer follow-up to patient, because it's important not only for you to see what's going on, but also that's data gathering time that you can use it that actually helps you understand that what you're doing is right, and it also gives you more credibility. Now, the algorithm, I'm not going to explain it I'll go to the other slides. I prepared a couple of tables for you that you can print and have it in your office if you want. You can learn it, and that kind of guides you to what is best to use in each patient, right? Remember, these are not carved in stone. These are just some guidelines that you can use. Let's say, so first, I want to start with a comparative analysis. And first, you need to have an accurate diagnosis. I mean, in order to treat someone right, you need to have some imaging studies. You need to have a proper evaluation. Don't just trust the patient that comes in telling you, I have tendinopathy, just because maybe they found it on Google or they misunderstood what his physician or clinician told them. So when you evaluate patients, cases of soft tissue like tendinopathy, for example, you can see that do very well with PRP, or cases of mild osteoarthritis. But cases of cartilage defect, for example, it's good to use bone marrow aspirate, and sometimes you can even combine that with PRP to get even a better result than just the bone marrow aspirate. So remember, these three are not competing against each other. They are often complementary too, right? In the cases of one question I've been asked a lot, even on patients that are surgical, well, then I'm not a candidate. Well, they can still be a candidate for PRP or for bone marrow stem cells to help promote better healing post-operatively. But if you're going to do that, make sure you do it at least 4 weeks after surgery, when the swelling has come down. Okay, when there's less complications, and when if something goes wrong from the surgery, the surgeon doesn't want to blame you for having touched the patient. Right? That's also important. Now, so step 2, what is that? It's important to also keep these factors in mind, right? Not just having the diagnosis, but look at the patient's age. Because you'll see a lot of people say, yeah, but I was told that I'm older, so I don't have as many stem cells. Well, in a patient that's older, I might not want to do a bone marrow aspiration extraction, although I still do. I have patients that are in the late 70s or early 80s, and I still do, depending, because they might not have a lot of fat tissue. So that's something to keep in mind. If the patient has a very large BMI of 40, I mean, I may consider doing an adipose draw. I mean, what I'm taking out is not enough to be a major plastic surgery, but it might create a difference in the patient's joint. Now, if the patient has a bleeding disorder, of course, we're not going to go with PRP. So always keep those things in mind. They're here on that table. Now, also, step 3, what would be? It's what are the prior treatments the patient has had and that outcomes. Like if the patient has failed very conservative treatment, I mean, you could consider trying just PRP. Now, what if the patient has had several sessions of PRP? Are we going to just put him on another PRP and badmouth another clinician saying they don't know what they were doing? Well, the reality is we don't know if what the patient is explaining to us is even accurate enough, right? They might not understand how to explain that well. So we can escalate that to what we think, well, PRP might not be enough to work. Let's go to level 2, and that might help the patient get a better outcome, right? Now, also, there are those patients that are surgical, and we just have to be honest with them and we tell them, you know what, I would not touch you, with a stick. I would send you to surgery, but for some reason they can't do surgery, either because they don't have insurance and they can't afford it, or simply, or they have a heart issue that they cannot have surgery. In that case, as long as they understand that, hey, this might not do the trick and give you what you want, but at least could make you a little bit better, that's important also to dedicate that time. And that's not a time that your PA or your nurse practitioner or your assistant should be giving the patient, talking to the patient. That's a time that you need to dedicate to the patient and respect them, explain that, and it would lead to them being more compliant and more understanding and to have a realistic expectation of what's going to happen. Anyways, aside from that, from the moral discourse, goals, what are the goals of that patient? Well, and what are your goals? If the patient just wants pain relief, I've had patients that say, you know what, my pain is 10 out of 10, doctor. And I said, well, you're going to go to surgery. No, I don't want to go to surgery. If I can alleviate my pain just a little bit, that will make me happy. If that can buy me some time, that can make me happy. So you can use this table to help you with that. Like if all we want is tendon healing of a tendon that's partially torn, but it's not that uncomfortable to the patient, PRP might do the trick, right? If it's something where we need bone integrity because it's a non-healing fracture or because it's a vascular necrosis, then a bone modulator like BMAC would be helpful in those cases, right? Now, if we're looking at durability, and this is very important, then a BMAC tends to show a little more durability than MFAT or PRP, but that's kind of just a gross guideline. It's ultimately it's going to depend on what exactly you're treating. Now, if the patient simply doesn't have the money for one of these treatments, then we have to also scale it back a little bit and not combine as much. So that's also something realistic that we have to consider. So when we use combinations, well, in cases like, for example, moderate to severe osteoarthritis that also has a lot of inflammation, you can mix PRP and MFAT, or post-surgical or cartilage repair, you can use PRP and BMAC. Easy. You can review those a little bit later on. So let's go to the fun part. Let's go to the case studies, okay? Now, the case number one, that lady with the elbow, right? Your staff told you in the office. This is a 72-year-old tennis coach that came with 6 months of right lateral elbow pain that gets worse with gripping, right? She tried conservative treatment. She tried physical therapy, shockwave, multiple things. And then she had a cortisone injected just 2 weeks ago. And she has a tournament in this next coming weekend. And imaging, the MRI shows an ERCB tendinosis, but there's no tearing, right? And the diagnosis is right lateral epicondylosis or tennis elbow, but chronic tennis elbow. What is the treatment? The treatment for that patient is send her home, right? Don't treat that patient. Why? She just had a steroid injected less than a month ago, right? And number two, that patient is telling you she has she's having a tournament in this coming week. That patient is desperate, and very likely cases like that, those patients tend to either not follow instructions, they don't take adequate rest because it's a tournament and it's important to her. A case like that, I just send her home and I said, after the tournament, take a week or two and then come back. So going to case number two is the former high school wrestler. There's a 63-year-old sedentary man with a bilateral knee pain of 8-year duration. It failed conservative therapy, and he has a BMI of 34. Now, he comes in saying, they say I'm bone on bone, which is very common. People come saying they're bone on bone, and they're really not bone on bone. That's just somebody, it's just, many orthopedic surgeons, unfortunately, many of my colleagues, they just don't explain it to a patient very well, or they had an assistant tell the patient, and that's what the patient understood. So in imaging, an X-ray shows some joint space narrowing and some medial meniscal degeneration. He had osteoarthritis stage 2 and 3, different on bilateral knees. What was the treatment for him? In this case, we did an MFAT injection after abdominal harvesting. And when we followed up this patient 6 months later, he had an improvement in pain scores, and he was able to defer his total knee arthroplasty in 1 year after evaluation. So his patient, he was a lot more functional, and that way, eventually he would need a total knee arthroplasty, but the last time we saw him, he had just postponed it, and that's exactly what he was looking for, okay? Now, case number 3. Oh, guess who's back? I said, it's the same lady that case number 1. She just showed up at your office without an appointment, and she's mad because she lost that tournament. And so when you see her, right, it's that tennis coach who has had the pain for 6 months, and she reminds you, and 2 more weeks because you made her wait, and she wants to get treated. Now, in this case, that you still do an ultrasound in office. And why is that? Because even though you have an MRI from last time, I don't know if she got a bigger injury or if something else happened. It's the responsible thing is to look at it again, especially when you have the ultrasound in office. You can do a brief evaluation, and ultrasound showed no change. So the treatment, we did an ultrasound guided PRP injection and followed up 6 weeks later, and she had resolution of her symptoms. Remember, MRI has shown that she had mild tendinosis, so she responded very well, and then left. Case number 3, and I'm almost done, guys. It's Those Hips Don't Lie. And it's a 36-year-old male, a gamer. All he does is professionally, he sits down and plays video games all day. He's had 2 years of worsening bilateral hip pain, and he plays video games 8 to 10 hours a day. And that's a reality of something we're facing. The video game world right now pays so well that people dedicate their lives to that. So he admits to very poor compliance with physical therapy. Keep note of that, right? And this patient has no health insurance. So he's coming to you because he won a lot of video game tournaments and he's willing to pay, but he still has no insurance because that would be too high of an expense for him to pay. Now, imaging shows subchondral signal change, and he has a vascular necrosis of bilateral hips with a collapse on the left, but no collapse on the right. Now, what was the treatment for him in that case? We did a bone marrow aspiration stem cells. Oh, sorry, I missed that one. Yeah, bone marrow aspiration stem cells combined with an injection of PRP. And following months, 6 months later, his right hip pain was reduced. There was no progression or difference in the MRI. Unfortunately for him, the left hip, which was collapsed, we weren't able to save it. So that ended up in surgery of one side versus both. So, but he had that realistic expectation. Now, what we did in his case, because we thought, you know what, I think we'll be able to save one hip. The other hip, I told him, I don't think I'm going to save it because I'm not going to think I'm going to be able to. So what we did is we just treated one time. I treated the other hip at no charge. I said, you know what, if it helps, great. If not, I don't feel bad that I charge you for that. So the fact that it did not produce any effects there, he was okay with that because he spent not a single cent for that. Now, case number 4, no one will cry on this shoulder. This woman comes in with 1 week old right shoulder pain, worse with her serve. She's a tennis player, and she felt conservative care. Now, she had a history of dislocation of the shoulder 20 years ago, and she went to another doctor who didn't explain things to her and just wanted to do a series of expensive injections. But she was referred by her tennis coach who said, you fixed her elbow, right? Now, on imaging, this patient came in with a partial intrasubstance supraspinatus tear with no retraction and some fraying of the labrum, which was expected from her old dislocation. And diagnosis, she had a partial right rotator cuff tear and some labral fraying. The treatment was a combination therapy of BMAC and PRP, and follow-up of 3 months. She had already improved pain and range of motion, and follow-up 6 months later, she had improved function and she was able to play in tournaments. And then she said that her coach sent her regards, who's also her mother-in-law and who's sending you a lot of patients. Now, what's important about that is that lady that you saw that one time that seemed kind of a little crazy has kept her eye on you and has kept sending you patients because you did something for her. You took the time, you respected her, you understood it, you explained things. Community. And that's it. And then you have my references in case you need to read a little more on that.
Okay. Thank you so much, Dr. Irizarry, for that informative and great presentation. So I usually enjoy your presentation. It's lots of new things and very to the point and result oriented. So is there any question from our audience? We have Dr. Miller. Dr. Miller is one of the key leader and pioneer in the fat and adipose tissue stem cells and the regenerative medicine. He, one of the key doctors, started using the fat and the regenerative medicine, and I have this opportunity working with Dr. Miller closely on different projects. So I'm looking through the chat. Jan, that's good. So everything is clear.
I just want to say that the two lectures were superb. I hope I can get a copy of both of them and that I can have them to be able to learn from. But they were both excellent. I learned a lot of stuff. And I'm just honored to be participating with these other esteemed colleagues and with EmCyte, and we're really excited about the future of regenerative medicine. And I think also it's very exciting to be able to validate our results with the EmCyte system. So, there's lots of discussion out there about, does PRP work? Does PRP not work? And the PRP is, in the words of Dr. Marks, who described PRP in the very beginning, PRP is not PRP is not PRP. So, I think it's very important for us to be showing the validation with our work, and that will completely separate, I think, EmCyte from all the other brands out there, especially the single spins, but all the brands out there. I think it's a great technology, and I'm just very pleased with the whole system. It's excellent. So.
Thank you so much, Dr. Miller, for your kind word and for your support. So there is a question, Dr. Irizar. I don't know if you could see the question in the chat.
I cannot. Let me see.
So I think I could read the question.
Yeah, read it. Yeah, absolutely.
So one of our audience asked, did you do a core decompression on the gamer with AVN?
Yes. As a matter of fact, I forgot to mention it, but yes, we did some core decompression. All these patients, even though I was mentioning more of what I was doing regenerative wise, I was doing shockwave therapy, sending physical therapist. I do have a certified orthopedic manual therapist that works with me in the office, so I was able to, I take the time to talk to the patient. I actually do some manual decompression myself while I'm talking to the patient and getting to know the patient better. So yes.
Okay, there is another question. They ask us, you discussed MFAT for tendon defects. Have you seen any data showing better healing of the partial tears with MFAT versus BMAC? So
I've seen comparable results with that, even though, so those I tend to choose. I know that MFAT tends to be better for soft tissue, but cases like that, and it was so complex that I actually do combination therapy at times and include PRP. But I use MFAT in those cases because of that little mass effect that I want to do to push that tissue if there's a little bit of retraction. But other than that, I've seen quite comparable results. I don't know in the case of Guyan or Randy, you guys, I mean, it's variable. So what do you guys think?
yeah.
For me, anecdotally, for sure, and with tendon tears and gaps, I like to use fat for that same mass effect that you're talking about. I like to usually I do a lot of combination therapy, so MFAT with PRP or MFAT with A2M. I've had good results with bone marrow. When I inject bone marrow into a tear, it leaves as soon as they move their shoulder, whereas the fat seems to stick around.
Yeah.
Mostly the purpose is scaffolding with the fat
Exactly.
to fill the gap, and yeah.
Exactly. And then if you're using that with PRP, the PRP is activating inside the body, inside the fat. That's the beauty of the whole, that's the magic combination. And I think also, just to comment on the question regarding outcomes, I think it's really important that we start, not just validating our results, but we start documenting our outcome results. And we're working, with EmCyte right now, and with data biologics to be able to include our information in a very objective way so that we can go back to the insurance companies and to the FDA and to everybody else who's questioning what we're doing and say, you know, this is specific outcome data here. So I think it's very important for us to document that.
Yeah.
Absolutely, absolutely. So, is there any question?
I also wanted to touch on that AVN case. I think the question about decork.
Yep.
So I've treated a bunch of AVN, and I've tried it both ways, where you do it intraarticularly or intraosseous, and I always find better results when you're doing an IO injection or you're injecting into the subchondral plate as opposed to just giving it intraarticularly.
Absolutely.
Yeah.
That's great. So, if there is
one other comment just regarding senescence, I think that's really important. You know, and I'm self-serving fat guy, adipose guy, but if you read the literature and you see how many MSCs there are in bone marrow aspirate in a CC, it's like less than 0.001%. So what are we actually injecting? What is that? It's the, you know, those are not, you know, mesenchymal stem cells. And then, you know, I also work a lot in the pharma realm where those cells are then expanded and they're worked really hard, and there's very few to begin with. So they're already old and tired, like at the very beginning. And then you compare that to a CC of adipose aspirate where you have hundreds of thousands of MSCs, and it's been shown scientifically that there's less decrease in number of adipose stem cells compared to bone marrow with age, and also significantly less senescence with adipose stem cells versus bone marrow. So, and I think we're going to get to the next point where we're starting to say that's going to be like the next frontier. And also just you know, on the, I know this is not really related to point of care therapies, but I'm also, you know, being involved a lot in the pharma world, I can tell you that immunomodulation and, you know, it's coming from everywhere. It's coming from bone marrow. It's coming from bone marrow exosomes. It's coming from mesenchymal stem cells, from umbilical cord tissue, from Wharton's jelly. It's coming from adipose tissue. All these patients are getting better. Like, it's just amazing to see how the regenerative properties. So we're trying to figure out, you know, which is the best source for which indication. But, you know, there's people being cured of COVID lung disease with bone marrow derived exosomes. Now, I would think they'd be the most tired exosomes you could ever find, but people are being cured of COVID lung disease with that through, you know, with INDs. So, you know, is that, and the same with perinatal products, and the same with adipose-derived products. So, you know, there's a lot of exciting stuff going on here, and I realize we're keeping this to the FDA-approved, you know, point-of-care minimal manipulation guidelines, which is obviously very important for us. But outside there in the pharma world and the other world, they're seeing a lot of stuff that's going to help us, I think, at the point of care.
Yeah. One thing to add, to chime into what you were saying, I agree. Adipose has so much versatility and it's a really good tissue, but it's important for everybody to learn if they want. But I advise everybody to learn to do a proper bone marrow aspiration. Why? Because you will get a patient like I got, an Abercrombie and Fitch model. Those people have like negative 10% body fat, and they want you to take it from fat. And where do you take it from? So in cases like that, I say, you know what, that's ideal, but this is what I can offer you, because ultimately it's what your body can take or will give me. Like, you don't have the building blocks or the materials for me to work with. So I cannot build you a cement house with just wood, right?
Yeah, and absolutely. And I'm going to tell you, I mean, we see all these elite athletes, just like you said earlier, and, you know, just like a thoroughbred. Like, where are you going to, like, we look under the tail and we find this little fat pad there, and we say, aha, there's the fat, you know. So, but yes, we need to be able to use other sources of regenerative with regenerative properties at the point of care. I mean, I was standing next to Kimbi Mutombo in Philadelphia at the football stadium, and I'm looking up at him, and he's like, I don't want anything except stem cells. I'm like, man, don't come to me for stem cells. You got no fat. You know, you need to go and get your bone marrow aspirated if you need to have that. But that's the reality. And also, I would say that I know EmCyte works a lot in the veterinary world. And, you know, that's another world, like the Dr. Sherman Knapp and Deborah Knapp. You know, we started working together because they were like, these service dogs have no fat. And they want to do fat injections for osteoarthritis for these TSA dogs and DEA dogs. And so they're going to the falciform ligament and, you know, almost basically into the abdominal cavity, which is, you know, pretty invasive to just get some fat to put into a joint. So I've actually been working with them, and we call it doggy lipo, but it's tricky. You know, we're trying to figure out a way to see how we can get some better fat out of these service dogs, but they're just like the elite athletes. They're the same. They have the same, you know, body composition, all muscle, no fat. So.
Yeah. Before we are done today, my message to everybody: eat some chips, eat some fries, store some cells in case you need them in the future.
I went to KFC yesterday, so I did my share.
That's great. That's great. Only one sentence regarding to fat, Dr. Miller mentioned. One key component we have in a fat we don't have in the bone marrow is dedifferentiated progenitor cells. And so I have a study, and I wish if I could talk in one of the upcoming conference about the potential of dedifferentiation of myofibroblast using the combination of the fat and PRP to treat the keloid scar, because it's a very unique feature when we combine at a right percentage of the fat with the PRP to dedifferentiate the fibrous tissue toward the adipose tissue. And then a body can recover itself to remove the keloid hypertrophic scar. And we can talk later through another webinar more about this. Thank you so much.
Yeah, I just wanted to, I know we could go on forever, but just to your point, fat is a tissue. Bone marrow is a space. There's no tissue in bone marrow. So you go, and I remember my first couple cases, you know, with Dr. Marks, scraping the walls, and I go, why are you doing all that scraping? It's like, because that's the only way to get the cells. You know, you could take a swimming pool full of adipose tissue and dive into it and not get hurt because it is tissue. And in that tissue is stromovascular fraction. And in that stromovascular fraction, as Arnie Kaplan showed us and many others, there are pericytes and perivascular cells and all kinds of amazing regenerative stuff that is not in bone marrow. It's only in adipose, because adipose is tissue and the bone marrow is a space. So I'll shut up after that.
We have one more question just posted. If you don't mind, I could read this one. Approximately, one of our audience asked, approximately how many milliliter of adipose tissue are typically required while liposuction to adequately prepare MFAT for a single injection into the rotator cuff, for example, supraspinatus tendon. Additionally, what volume of the MFAT is typically injected into such a site for therapeutic effect?
Go ahead, guys. This is your wheelhouse.
Go ahead.
Yeah, no, go ahead.
So for me, I mean, it depends on which system you're using, but I typically will try to get 4 cc's of adipose aspirate or after it's been decanted for every 1 cc of final product I want to use. Sometimes I over harvest, but I guess it's always better to have more than less. As far as volumes for injections, I think you would just have to be mindful of what the tendon is going to tolerate. For example, today I did a rotator cuff tear in a patient with microfat, and her tendon took 2 cc's without really any issue. And there's times where I'll inject on 0.5 and they're screaming, and you don't have, you cannot go anymore. So you just have to be kind of, you estimate between half and two per tendon in a joint. You just have to think about what the joint's going to tolerate. A glenohumeral joint, 5 to 7 cc's,
Mhm.
a subacromial space, 1 to 2 cc's. I mean, you just have to kind of know what it can take and what it can't.
Yeah, remember that a tendon is a solid structure. So if you're injecting into a solid structure, first always use visualization, right? Use an ultrasound or something so you see where you're injecting. And when it's a solid structure, it would offer resistance. And just like you're injecting, once it's full, don't keep pushing it and shoving it like it's a eating competition, right? Because eventually that tendon is going to tear more if you're forcing the tissue in. So it kind of gives way. Now, if you're seeing the tear, you kind of feel, I mean, you feel the tear a little bit, you see, but like Dr. Gayan Pubharendran says, it's about 2-3 cc's at most on a typical tendon, but the joint takes a little more space, yes.
Yeah. But now the next frontier is taking that microfat and creating nanofat and saying, okay, now we want to take these amount of cells and we want to turbocharge and really concentrate the amount of MSCs and exosomes in an autologous FDA compliant way. And where I think this is really important is, like, for example, I'm a hand surgeon as well as a plastic surgeon. So like if we're doing a small joint and you want to try to get as many MSCs in there as possible, then you really don't want to use microfat. You really want to use nanofat and combine nanofat with PRP. So that's, I think, going to be kind of like the next frontier, and how we can even get, and there are already papers to show that the biologic activity of nanofat done with just mechanical process has more biologic activity than enzymatically dissolved adipose tissue. So it's not only it's more active, and also I think probably it's more active because it's containing more of those stromovascular fraction and the more of those connective tissue elements that are there. But remember, with nanofat, we're kind of squeezing it like an orange juice, so we're really squeezing to get all those stem cells and the exosomes. So we do probably lose a little bit of stromovascular fraction and connective tissue in the filter, but there's what comes through is highly concentrated, and easy to inject. That's the other thing I think that's very important, is the fluidity and the ease of injection. If you blast it in there and you don't have control, that's definitely not a good thing. And then also, just with regard to the harvesting part, a lot of times the first syringe that you take out is mostly tumescent fluid, because you put the tumescent fluid in. So if you're really looking for the big guns, probably you want to use the middle syringe. The middle syringe is the one where you're getting like the beautiful, fat. And then the last syringe is the one that has the blood in it, where you go, oh, geez, I better stop and not do this anymore. But the middle syringe, usually, has lots and lots of adipose tissue. And also just, we did a really interesting case with EmCyte, where there was a patient with like 5 different areas of muscular of MSK pathology, and I said, if we're going to mix up PRP and nanofat, we have to have the needles in there. Because once you touch the PRP to the nanofat, it activates, and you have like 10 seconds to get it out of the syringe. So we localized everything with ultrasound, with needles. And then we said, okay, mix, mix, mix. This is for injection number 1. Mix, mix, mix. This is for injection number 2. And then keep the PRP and the nanofat separate so that nothing is activated until it's ready to go into the body. So sorry to talk so much, but I thought
The question in the following question is how you prepare the nanofat. So using different.
Yeah. So basically, it comes down to, first you need a good harvesting cannula and a good system, and you need to have, you don't want to have like giant chunks of fat. You want to have particles that are the right size for the procedures, that you're doing. And then we run the adipose tissues through serial lure-to-lure transfers, 2.4, 1.4, 1.2. And basically the Venturi effect of going back and forth kills most of the adipocytes, but the stromal-vascular fraction and the stem cells are very strong and they're small. So they survive that Venturi effect very well. And then once we do that through the 1.2, then we take it and we put it through a nanofilter, and the nanofilter is what really kind of removes the fibrous tissue, and then we collect the, kind of the fluid nanofat, coming out the other side without all the fibrous component. But we do not touch it to the PRP. We don't even keep them on the same table, because I've made the mistake, I'm not going to tell you how I know this, of mixing up all the PRP and all the fat and then saying, geez, I can't use any of it because it just all activated and it's all stuck in the syringe. So I'm not going to tell you who did that, but his initials are RM. So
I've been there before when I was much too zealous.
Right.
That's great. So yeah, I think we answered all of the questions. Thank you so much. I really appreciate your time. And it was one of the great webinar we had so far. Very informative, and I learned a lot.
Me too.
It's truly my privilege working with all of you closely as EmCyte representative. You are as EmCyte clinical board. So yeah, I really appreciate that. So thank you so much again. Just for our audience, our next webinar is gonna be early August. And so based on some requests and feedback, we decided for the next one, run the webinar with the topic in the reproductive medicine and fertility medicine field, which is one of the hot field using the PRP. And so I hope we could provide a very, very informative and good webinar for that session as well. Again, thank you so much. And I wish a very, very great and wonderful evening for all of you, the US, outside of the US, in our audience through the Europe and Asian countries.
Thank you.
Thank you so much.
Thank you so much.
Thank you, guys.
Bye.
Thank you for joining us in this session of EmCyte's webinar series. Stay tuned for our next episode as we continue uncovering the science behind precision biologics.